Okay, let's unpack this. Think about the last time you were at the doctor's office, maybe getting a checkup or seeing a specialist.
Mm-hmm.
You get the care you need, you leave, and then somewhere down the line, usually days or weeks later, bills arrive.
Right.
For the patient, it feels like the end of the process.
Yeah.
But for the healthcare provider, that clinic, that hospital, that lab, getting paid for the service they provided, that's a whole separate, incredibly complex journey.
Oh, absolutely. It's like the engine that keeps the lights on, the staff paid, and care accessible. We are talking about medical billing.
Exactly. The critical, often unseen backbone of the entire healthcare financial system.
That's right. You can provide world-class medical care, but if you can't navigate the billing process effectively, you simply can't stay in business. It's fundamental.
And for this deep dive, we've tackled a really comprehensive guide on exactly how that works. Our mission.
Yeah.
To cut through the jargon, the complexity, pull out the most important insights, and give you a clear, actionable understanding of this vital process.
Turning that source material into essential knowledge.
Exactly. Knowledge you can actually use, whether you're looking at your own medical bills or just curious about how this massive industry functions financially.
So let's start with the fundamental question. What is medical billing?
Okay.
At its heart, it's taking the services a provider rendered, say, a doctor's visit, a procedure, a lab test, translating those services into a standardized request for payment.
A claim.
Right, a claim, and submitting that claim to the patient's insurance company or other payer. The biller is essentially the financial translator and navigator between the provider and the payer.
So it's way more than just sending an invoice then.
Oh, much more. It involves ensuring the claim is accurate, submitted correctly and on time, tracking its progress, following up on, denials or rejections, and managing the eventual payment or collection of patient balances.
It's the full cycle.
The full cycle of getting paid for care, yeah.
And you touched on something important there, translating services. The source material makes a really clear distinction between medical billing and medical coding. Can you walk us through that difference?
Absolutely. They are intertwined, definitely, but they're different roles. Medical coding is the process of assigning standardized alphanumeric codes to diagnoses, procedures, services, and supplies.
Like the ICD-10 codes.
Exactly. You've probably heard of some of the major code sets. ICD-10 for diagnoses, CPT for medical procedures and services, and HDPCS for things like supplies or drugs.
Okay, so if I go to the doctor because my knee hurts and they diagnose me with, say, tendinitis, that diagnosis gets an ICD-10 code.
Precisely. And if they then decide to give you a steroid injection into the knee, that injection procedure gets a CPT code.
Ah, okay.
The coder reads the doctor's notes and documentation and translates everything that happened clinically into these universal codes.
Got it. So coding is translating the clinical story into code. And billing then is?
Billing takes those codes, bundles them up with all the patient's demographic and insurance information, puts it onto the correct claim form,
Right.
and handles everything that happens after the service is documented and coded, submitting the claim, chasing payment, dealing with issues. Think of the coder as creating the coded language description.
The blueprint.
Yeah, the blueprint of the service. And the biller as the one who uses that language to make the financial transaction actually happen.
That makes sense. Coding is the technical language, billing is the financial operation, using that language.
You got it.
And this whole operation fits into something even bigger, revenue cycle management, right? RCM.
Yes, exactly. RCM is the overarching process. It covers the entire financial life of a patient encounter from the moment they schedule their appointment.
All the way to the end.
All the way to the point where the final dollar, whether from insurance or the patient, is collected. Eligibility verification, patient registration, coding, charge entry, claim submission, payment posting, denial management, collections. Medical billing is really the core engine within that larger RCM cycle.
So who are all the different players involved in this intricate dance?
Well, at the center, you've got the patients receiving the care and the healthcare providers delivering it.
Naturally.
But it's the payers, primarily insurance companies, that are the main source of revenue. Then you have significant government agencies like the Centers for Medicare and Medicaid Services, or CMS.
They run Medicare and Medicaid.
Exactly. Huge programs. And CMS works with the Office of Inspector General, the OIG, on compliance and fraud prevention. And of course, the medical billers themselves are the skilled professionals navigating this landscape. Plus, the source also highlights the role of clearinghouses.
Clearinghouses. Okay, What do they do in this process? They sound important.
They are. They act as intermediaries, sort of like a crucial pit stop for electronic claims. Providers send their claims data to the clearinghouse first.
Before it goes to the insurance.
Yes. The clearinghouse scrubs the claims. They check them for thousands of potential errors like missing information, incorrect codes, or formatting issues before sending them on to the individual payers.
Oh, wow. So they catch mistakes up front. That seems incredibly valuable.
It really is. They clean up the claims, make sure they're formatted correctly for the specific insurance company, which significantly cuts down the number of claims that get rejected immediately by the payer just for technical reasons.
Saves time and headaches later, I bet.
Absolutely. Then they batch and transmit them electronically to the various insurance companies. They streamline the whole submission process and act as a vital quality control step.
Speaking of insurance companies, navigating the payer landscape in the U.S. is, well, notoriously complex. It's not just one system, is it?
Oh, far from it. The U.S. healthcare system is a real patchwork, largely driven by a mix of private insurance and government-funded programs.
Let's maybe break down the major types of insurance a biller deals with, starting with the government side.
Okay. The big ones are Medicare, primarily for seniors and certain disabled individuals. It's split into Parts A, hospital, B, medical services, and C, which is Medicare Advantage, run by private insurers.
Right.
Then there's Medicaid, for low-income individuals and families. That's jointly funded by federal and state governments, and the rules can vary significantly by state.
A lot to keep track of.
Definitely. Other significant government payers include TRICARE for the military community, CHP for children and families just above Medicaid income limits, and the VA for veterans.
Okay, so a whole alphabet soup of government programs, each with its own unique rules, which must be a challenge for billing.
It absolutely is. And then you have the massive world of private or commercial insurance.
Right, the ones offered by employers or that people buy directly.
Yes, plans from companies like Blue Cross Blue Shield, Aetna, Cigna, the big names.
And within that, you've got different flavors of plans, right? Like PPOs and HMOs. I always get those confused.
Yeah, the source mentions the common types. PPOs, preferred provider organizations, they usually offer more flexibility to see out-of-network doctors, but often at a higher cost to you.
Yeah.
HMOs, health maintenance organizations, they often have lower premiums, but you generally have to stay within a specific network and often need referrals to see specialists.
More restrictive.
Typically, yes. Then there are EPOs, exclusive provider organizations, kind of like HMOs, but sometimes without needing referrals, and POS, point of service plans, which are sort of a hybrid, offering more options than HMOs, but maybe with different cost tiers depending on the network.
So each plan type within each company can have different rules about deductibles, copays.
Exactly. Different rules, different covered services. It's complex.
And we shouldn't forget the self-pay patients.
Right. Good point. These are individuals who are uninsured. Maybe their plan doesn't cover a specific elective service, or they just choose not to use their insurance.
What happens then?
For those patients, the responsibility is typically the full charge for the service, although providers often have policies for offering discounts or, setting up payment plans to help manage the cost.
So you've got this really diverse mix of payers, government, private, self-pay, each with their own contracts, rules, and procedures. That means medical billing isn't just about knowing codes.
Not at all.
It's about knowing an incredible amount of complex regulations and legal requirements, too.
Exactly. And a huge piece of that puzzle, especially in the U.S., involves compliance. Navigating this system means adhering to some really significant healthcare laws.
The big one that comes to mind is ICHE-PAYA.
Right. The Health Insurance Portability and Accountability Act. Yes, this is foundational. It's all about protecting sensitive patient health information, what's known as PHI.
Protected health information.
Right. The privacy rule dictates how PHI can be used and disclosed, and the security rule sets standards for protecting electronic PHI. The source really stresses the importance of secure handling of electronic claims. Data encryption is often key.
And the consequences for messing up HIPAA.
They're serious, ranging from hefty fines potentially up to $1.5 million per year for certain violations to even criminal charges in cases of malicious intent or severe negligence.
Wow. So getting patient demographics slightly wrong is one thing, like a typo.
Which can still cause problems, mind you.
Right. But mishandling their private health data has major legal repercussions.
Absolutely. It's not just an administrative detail, it's a fundamental legal and ethical imperative. And related to navigating the rules and avoiding legal trouble is the constant vigilance against fraud, waste, and abuse, FWA.
Okay, FWA.
Mm.
This sounds like the darker side of medical billing.
It certainly can be. Fraud is intentional deception for financial gain. Waste is incurring unnecessary costs due to inefficient practices. Abuse involves obtaining improper payments through actions that aren't necessarily intentional fraud, but still deviate from sound medical or business practice.
What are some common examples?
The source lists things like upcoding billing for a more complex or expensive service than was actually performed.
Claiming you did more than you did.
Essentially, yes. Or unbundling billing separately for components of a service that should really be billed as a single combined CAD. Billing for services that weren't medically necessary is another big one, or simply submitting duplicate claims for the same service.
And the source provides some pretty eye-opening examples of how serious the consequences can be for FWA. These aren't small mistakes.
No, they're not. There's the case mentioned in Miami where a healthcare network was involved in a massive, $1 billion fraud scheme, bribing doctors for unnecessary treatments. It resulted in the CEO getting a 20-year prison sentence.
20 years.
Yeah. Another example is a hospital chain that had to pay a $250 million fine for systematically inflating billing codes, basically upcoding, and a cardiologist sentenced to 10 years for performing fake heart procedures on patients.
Unbelievable. Fake procedures.
It happens. These examples aren't minor slaps on the wrist. They show the severe legal penalties and financial costs associated with FWA.
Wow. $1 billion in fraud. Multi-million-dollar fines. Actual prison time. It really underscores just how high the stakes are in getting billing right and, importantly, staying compliant.
It really highlights the necessity of diligence, accuracy, and strong ethical practices. The source also briefly mentions the False Claims Act, which penalizes submitting false claims to government programs like Medicare, and the anti-kickback statute, which prohibits exchanging anything of value for referrals for federal healthcare services.
More layers of rules.
Both carry significant penalties and are key tools in combating FWA.
Okay, so with all these layers, different types of insurance, specific patient plans, strict compliance rules, let's get back to the actual process itself. How does a provider actually take that patient visit and turn it into a claim ready to be submitted? Where does it start?
It truly starts right from the moment the patient interacts with the front desk. The first key steps in the RCM process are patient registration and eligibility verification.
Getting the basics right.
Absolutely vital. Getting accurate patient demographics, name, date of birth, address, and crucially correct insurance details like policy ID and group numbers. Small errors here, like a misspelled name or an incorrect birth date, can easily lead to claim denials down the line.
So accuracy at check-in is really paramount.
Exactly. And verifying the patient's insurance eligibility before the visit is also critical. Confirming the policy is active, understanding their benefits like copays or deductibles, and checking if the specific service might require prior authorization from the insurer. Doing that up front can prevent major headaches later.
Okay, so the patient is registered, their insurance is verified. What happens after the actual clinical service is performed?
That's where medical coding and charge entry come back in, circling back to our earlier discussion.
Right, the translators.
Medical coders translate the doctor's notes into those standardized ICD-10 codes for diagnoses, CPT codes for procedures, and HCCCS codes for supplies or other services. And a fundamental concept here, really stressed in the source, is medical necessity linkage.
The why has to justify the what. I think you said that before.
Precisely. The diagnosis code must clinically support the procedure code. If the diagnosis doesn't clearly explain why the procedure or service was necessary, the payer is likely going to question it and probably won't pay.
Can you give that example again?
Sure, the example from the source is perfect. A patient comes in with an ankle sprain. Let's say the coder assigns ICD-10 code S93.402A for that specific sprain. The doctor orders an X-ray, which has CPT code 73610.
Okay.
The sprain diagnosis provides the clear medical necessity for taking the X-ray. But if the diagnosis was just something vague like Ankle pain, unspecified. Without more detail in the notes, the payer might push back and say the x-ray wasn't justified based on the coding.
So the codes aren't just random identifiers. They have to tell a coherent, medically logical story that the insurance company evaluates.
Exactly. Once the services are coded and the charges are determined based on the provider's fee schedule, then charge entry specialists enter all this information, the codes, the charges, the patient info into the medical billing system.
Which is typically done in what's called practice management software, or PMS.
Yes, the PMS is this central hub. It's where patient data, scheduling, billing, and claims management all happen. It's where the formal claim document is actually assembled.
What information actually goes onto that claim form? What are the key pieces?
The source details the key components. You need the provider's information, the patient's identification details, the specific dates the services were provided, the coded services, CPTH, CPCS, correctly linked to the diagnosis codes, ICD-10, the billed charges for each service, and of course, the patient's insurance information.
Sounds like a lot of detail.
It is. They also mention super bills, which are like detailed receipts or itemized lists of services and codes. Patients sometimes use these for self-submission to insurance, especially for out-of-network care or just for their own records.
And how do these claims get sent off to the insurance companies? Is it still paper sometimes?
Overwhelmingly electronic now, using electronic data interchange, or EDI. The standard formats are called EDI 837 Professional for services like doctor visits. That's the electronic equivalent of the old paper CMS 1500 form.
Okay.
And EDI 837 Institutional for facility services like hospital stays, the electronic version of the UB04 form. While paper claims on those forms are still used sometimes, maybe by very small practices or in specific situations, electronic submission is really the standard. It's far faster, more efficient, trackable, and more secure.
And this is where our friend the clearinghouse comes back into play, right? To handle the electronic submission.
You got it. The provider typically sends the electronic claim file, the EDI 837, to the clearinghouse. The clearinghouse performs that crucial claim scrubbing step we talked about, checking for common errors that would cause an immediate rejection by the payer.
The pre-check.
Exactly. It then formats the clean claim data correctly for the specific payer's system requirements and transmits it electronically to them. This pre-submission check drastically reduces the number of claims that just fail at the first hurdle with the insurance company due to simple mistakes.
Okay, so the claim has been built, scrubbed by the clearinghouse, and sent electronically to the payer. Now it's on their side of the fence. What happens then?
So the payer receives the electronic claim and begins their internal review process, which is known as adjudication.
Adjudication. Sounds formal.
It is. They're basically judging the claim. They're checking things like, is the patient actually covered under this policy on this date of service? Is this provider in network for this plan? Is the service itself a covered benefit under the patient's plan? Does the medical necessity seem supported by the codes and any attached documentation? Are the codes themselves valid and used correctly?
A lot of checks. And this is where the provider might get a denial, right?
Yeah.
Or maybe a rejection. The source made a point about the difference between those two.
Yes, it's a really important distinction in the billing world. A rejection happens before the payer's system really fully processes the claim. It's usually an immediate flag for a technical error or missing basic data like an invalid member ID, maybe the date of service is outside the policy affected dates, or just basic formatting issues detected by their initial computer checks.
So it bounces back quickly.
Right. These are typically fixed relatively easily, correct the typo, update the ID, and then the claim is resubmitted. Think of it like the post office returning your mail. Because the address label was incomplete or unreadable, they didn't even really look inside.
Okay, so rejection is a technicality before they even open the envelope, so to speak. What about a denial then? That sounds more serious.
Like denial happens after the payer has begun processing the claim. They've looked at the details, but for a specific reason, they've determined they won't pay for the service, or maybe part of the service. This could be because the service isn't covered by the patient's specific plan benefits, or maybe prior authorization was required but wasn't obtained beforehand. Lack of medical necessity, as we discussed, is a big one. Or it could be a duplicate claim submission. Or maybe the patient's insurance had actually expired on the date of service. Denials require more investigation and potentially filing a formal appeal.
So a denial is like they did open the envelope, read the contents, and sent back a letter saying, sorry, we're not paying this, and here's the specific reason why. What are some of the most frequent reasons for these denials?
The source lists several key culprits. Simple things like incorrect patient information, a typo in the name or policy number. Lack of medical necessity. The codes don't justify the service in the payer's view. Expired insurance on the date of service. A big one is failure to obtain required prior authorization.
Forgetting that permission slip.
Exactly. Also, the service simply being non-covered by the patient's plan, maybe it's considered experimental or cosmetic, and duplicate claims submitting the same service twice. That simple case study example in the source, where a denial occurred just because the patient's name was spelled slightly differently in the provider's system than on their insurance card, really hammers home how small details can have big financial impacts.
Just a simple spelling mistake can hold up potentially thousands of dollars. That's wild. So if a claim gets denied, is that just lost revenue for the provider? Game over.
Absolutely not, or at least it shouldn't be. Effective denial management is a crucial part of good medical billing. The biller needs to investigate the reason code given for the denial, figure out what went wrong.
Play detective.
Pretty much. They might need to correct errors found, like updating patient info, adding a missing modifier code we'll talk about later. Gather supporting documentation, like maybe the physician's detailed notes proving medical necessity. And if it seems the denial was incorrect, file a formal appeal with the insurance company, adhering to their specific appeal process and deadlines. It definitely requires detective work and persistence.